Welcome everybody back here for our second day of the Jorvet Wholesome Patient Care program that we have going. Today we are talking about compassionate solutions for the open wounds, and we have Dr. McNulty here. He's a professor of surgery at the University of Wisconsin and the chair department of the surgical services. Welcome. Welcome to our talk today. We're very excited to have you.
Well, I'm excited to be here. This will be a little bit of a new experience for me. When I was asked to talk about wound care, I was trying to think of what's the greatest value I could bring into this type of discussion. And I thought that a focus on our invention, the microlite wound dressing, and describing, how it's built, how it works, because it is a completely new technology. And I thought that would be useful for people to become more familiar with it. As a disclaimer, I have to let everyone know that I am a co-inventor of the microlite wound dressing. This is an effort with multiple labs at the University of Wisconsin. And I'm a co-founder of the company that produces and markets this for both human medicine, which it's been really taking off in human wound care, and in the veterinary arena. Although I'm not involved in the business or running embed biosciences in any way. So just to go into basic wound healing. We all know about the basic phases that occur during the wound healing process. So there's an initial hemostasis, we have an inflammatory stage, then we go into a proliferative repair stage and remodeling and maturation of the scar. So I'm not going to belabor those. I think everyone in this webinar is going to be familiar with that. But one thing that tends to get overlooked is that these wounds can be overrun by bacteria and have biofilms form. And it's been shown that when that occurs, that can cause these wounds to stall out in the inflammatory phase. And we basically get recalcitrant wounds that then have difficulty healing and can end up being managed for very long periods of time. I'm going to have to try and, there we go. So a few basic principles of how we currently manage wounds. We do debridement, our most common first stage strategy. And, our goal there is to convert the wound bed to a clean, atraumatized wound bed. So that's going to give us better quality of granulation tissue. We'll get better wound contracture, and we'll have reduced complications when we finally consider our primary closure strategy. This is going to accelerate the inflammatory phase. So the entire idea of our initial wound management is to get through that inflammatory phase as rapidly as possible. And our debridement can be macroscopic. So scissors and forceps will cut away all the damaged tissue, but then we frequently do microscopic debridement using wet to dry dressings. And that's been a mainstay for many, many decades in wound management. And then ultimately we'll determine a closure strategy. And ideally, we get to a resolution of that wound. There are some problems, though, in that approach. So one is, how do you prevent bacteria from taking over your wound surface and ending up with a wound that's stalled in that inflammatory phase? So it's virtually impossible to keep these wounds absolutely sterile. They'll be have inoculation of bacteria during the initial trauma. Certainly, any surgical procedure has the potential for allowing bacterial to get on those wounds, either during debridement or closure of the wound. During the postoperative period, if there's an open wound, they're susceptible to bacterial colonization, and certainly environmental exposure, such as in the hospital, where we often end up with resistant nosocomial bacteria on these wound beds. Some of the bacterial colonization can be propagated or facilitated by the fact that, we have traumatized tissue in the wound bed, and we may have debris in that wound bed. That debris could be foreign matter, or it may be dead tissue or cells, which is typically the two things that we're targeting when we start looking at using wet to dry dressings. We may have exposed foreign bodies, such as down here in the lower right, where you have a wound that's opened up and we now have exposed bone plates. And then the virulence of the organisms that colonize these wound beds and whether or not they're prone to biofilm formation are certainly big factors, and whether we're going to have problems with bacteria during our wound management. So the result, if bacteria are able to sort of win that race as we're managing these wounds, is that we get stalled healing, prolonged wound therapy. It may compromise our surgical repair. Lots of clinic visits, and client satisfaction is certainly reduced as these things drag on. So our wet to dry dressings are really a microdebridement tool. And this has been a classic approach to wound management for a very long time. And for many wounds, it's generally effective. We can use it for a period of time in order to do microdebridement of dead cells, small bits of tissue, and taking out really small bits of foreign matter. And it helps the wound to be cleansed and helps stimulate granulation tissue formation. When we do this, these dressings absorb wound fluid. They exfoliate debris from the wound surface and strips loose non-viable cells and tissue from that wound surface. And in many cases, this can promote a good, healthy wound environment and help us to get to a point where we can do our primary closure. So the real issue becomes those cases that this does not seem to work, and we end up with stalled wound healing due to bacterial overgrowth. So one of the challenges of wet to dry dressing is, although it's a great microdebridement tool, it also provides an excellent environment for bacterial colonization and proliferation, and particularly in the early phase of using the wet to dry dressing. So it creates a warm, moist, nutrient-rich environment on the wound surface. So that's very good for fibroblasts and capillaries growing in there to form granulation tissue, but it's also great for bacteria. We typically use it when there's debris of some sort present in the wound. So whether that's foreign matter or dead cells or tissue, having foreign non-viable debris in the wound does tend to make the bacteria better able to gain a foothold on these wound beds. And so there's this balance between trying to remove that before the bacteria can really gain a foothold on the wound bed and colonize the surface. Wet to dry dressings, not as effective in topographically complex wounds. So like on the left here, if you have wounds with big crevices, it may be hard to get contact of the wet to dry dressing to that wound surface. And then the question is, if bacteria are able to colonize this wound, is it what we used to, a couple decades back refer to as the normal flora that are going to grow on wounds? And these would be non-pathogenic bacteria that don't seem to cause any problem. Or is it going to be a pathogenic colonization of bacteria that are more damaging to the wound healing processes and are able to create biofilms? In people, what they've shown is that 60% or more of chronic wounds have demonstrable biofilms on their surface. And that's probably an underestimate due to the technical difficulties of actually demonstrating true biofilms versus just bacteria, whereas they found only 6% of acute wounds had detectable biofilms. So formation of biofilms and chronic colonization of these wound surfaces is a big problem. So what are our overall goals when we're managing these wounds prior to closure? Well, we do want to prevent or eliminate bacterial growth to the best of our ability on these wound surfaces. We don't want local cell toxicity, so we don't want to impair the ability of fibroblasts and capillaries to form and form nice, healthy granulation tissue. We certainly don't want any toxic systemic side effects. We would like to have a technology that's effective for severely resistant bacterial strains. So this is a huge problem now in veterinary medicine. We see resistant multi-antibiotic resistant bacterial strains every day in the clinic, multiple times a day even. We want something that's technically easy to apply and ideally cost effective as well. So that there's been a lot of approaches to antimicrobials in wounds, and probably the most common has been antibiotics, both topical and systemic. Um, and the big issue with topical antibiotics is there's a relatively low residence time for topical antibiotics on a wound surface due to absorption of the antibiotic and into the tissue and then dispersion to the systemic circulation. And then also resistance. So it can be difficult to find an appropriate antibiotic that's going to be effective against the organisms that are present on the wound surface. Manuka honey is kind of trendy, and it's relatively inexpensive. No real resistance to Manuka honey. It probably acts through a combined effect of both an osmotic action and due to the presence of antimicrobial peptides that are thought to be at higher concentrations, particularly in the Manuka type honey. But I've not found this to be really a silver bullet, so to speak, in terms of treating all wounds. And there is some handling issues in terms of putting the honey on the wounds and keeping it in place, and how frequently you may need to reapply that. There's some high-tech wound dressing. So Procellera is one that deals with electrical fields, extremely expensive. Efficacy has really not been studied in veterinary medicine, and due to its high cost, it probably never will gain a great foothold in our field. Can't be used if you're going to do any sort of energy-based procedures such as radiation therapy or ultrasound, and of course needs to be removed after the therapy. For silver dressings, silver sulfadiazine is a classic cream that's been used in both human and veterinary medicine on burn patients. Interesting thing with silver sulfadiazine is when we were doing our original research on the microlite dressing, we used silver sulfadiazine as one of our control groups. And what we found is we actually got no reduction in bacteria on those wound surfaces with silver sulfadiazine. So I think its efficacy is relatively limited, even though it's been used for since the 1950s in wound care. A newer dressing is Acticoat. This is probably the #1 silver-containing dressing on the market. It's quite expensive. The big issues with Acticoat is that it uses a tremendous amount of silver, and so there are tissue toxicity issues related to Acticoat. And its actual FDA claims that are allowed basically only allow it to be used in wounds that are already infected. So it's basically the lesser of two evils in terms of having some damaging effects to the cells in the wound, but still able to kill the bacteria. So what I want to talk about is this new technology for wound care, which is the microlite vet. So this is an ultra-thin bioresorbable matrix. And this is a totally unique form factor. There's nothing else like it that's out there. And one of its advantages is that it's conformable to the micro contours of the wound surface topography. So that allows it to immobilize the silver nanoparticles right at the cell surface, even though the wound surface may be very uneven. This provides a long-term release of antimicrobial silver, and it's non-cytotoxic because of the fact that it uses relatively low concentrations of silver, and it's still able to be just as effective as an antimicrobial as something like Acticoat. The way this membrane is built is that it's about 100 or more layers of a polyelectrolyte polymer, and they're charged positively and negatively, and they're stacked up on top of each other until we form about 100 nanometer thick polymer multilayer. And then that's doped with ionic silver, and then that ionic silver is reduced in situ to the nanoparticles. So the nanoparticles are very uniform in size, giving us a very predictable release of ionic silver. And they're also immobilized within this polymer multilayer, so they're held right at the cell surface when this is applied on the wound bed. The reason this is advantageous is that allows us to use very low concentrations of silver because the ionic silver is being released right at the area of bacterial adhesion. And so it's more effective as an antibacterial and it's less likely to become inactivated by reacting with wound fluid proteins. In contrast, these thicker silver-containing dressings like Acticoat, they can't really conform to the wound bed at that microtopographical level. And so the way they overcome that issue is they use very high levels of silver in order to essentially flood the wound and get past the issue of the ionic silver being inactivated by the wound fluid proteins. But this then gives a relatively uncontrolled release of silver, and that's the reason why those products have cytotoxic side effects on your wound bed. Now, when this polymer multilayer is formed, since it's only about 100 nanometers thick, you really can't handle that. And so in order to make this a practical product, there's a layer of polyvinyl alcohol that's added to it. So it thickens it up into the micrometer scale. And that polyvinyl alcohol will then dissolve due to absorption of interstitial fluid when it's laid on the wound. So again, the key mechanism of action with the silver is the fact that because this is a nanometer scale thick polymer multilayer, and it holds those silver nanoparticles immobilized right at the cell surface, is that we get extremely high killing of bacteria. So we get 99.9% killing of bacteria, and using only very low levels of silver to kill the microbes. So about 100-fold less than other products that are out there. The other thing that this nanofilm provides is actually a nanoscopic protective layer over the wound surface. So we can use this as a sole wound dressing in some applications. We typically will put it under a primary dressing, but there are areas where a primary dressing is not very practical, and we can use it as a sole dressing. And that nanoscopic layer also helps with some of the pain that's associated with these wounds. So in humans that we've been using this in, they report an increase in comfort of their chronic wounds. Obviously, we can't ask our veterinary patients that, although we do have some evidence from veterinarians in the field that this is relevant to our patients as well. The fact that this polymer multilayer provides this barrier on the wound, it's important to recognize this is not an occlusive layer, though. So gas, in particular oxygen, can transmit through it as well as water vapor. So it's a non-occlusive nanoscopic protective layer that goes onto the wound surface. So to give you an idea, this is a video that was provided to us, and I apologize for the dramatic music. Provided to us by Dr. Bryden Stanley at Michigan State. And what this shows is both the integration of this nanoscale polyelectrolyte layer onto the wound, and also the ability that you can customize this to the wound shape. So once the material adheres to the wound, you can pull off the excess around the outside and basically end up with a treatment that's just totally focused on the open wound that's present. It also adheres to the microtopography of the wound. And so this is an example, one of our early cases at the University of Wisconsin. And I'm going to try and skip ahead because of our time limits here. And this will give you an idea. So when we look at spontaneous adhesion of this material, what you're seeing is adhesion of the polyelectrolyte multilayer to the microcontours of this relatively complex wound surface. And the areas where you see this starting to dissolve, that's the polyvinyl alcohol that's now absorbing fluid from the interstitial space of the wound bed and then dissolving, and that polyvinyl alcohol just dissolves and washes away. But the polymeric multilayer will stay on the wound and immobilize that silver on the wound surface. So some advantages of this approach for veterinary care is, as I mentioned, it's non-cytotoxic. It'll conform to those complex wound surfaces. We can put it in cavities, so under wound pockets, we can wrap it around a gauze sponge and put it under overhanging tissue shelves. It's been used in tooth sockets, both in small animals and in equine practice, with good effect. Bacterial development of bacterial resistance to silver is extremely rare. So you can go on in the PubMed and look for bacteria that are resistant to silver, and you can find laboratory projects where they've been able to demonstrate that. But there's not a tendency for bacteria to develop resistance, and bacteria that are spontaneously resistant to silver is relatively unknown. We've shown that it eliminates 99.9% of bacteria when we've done our efficacy testing. And it also provides a prolonged release of silver. So the FDA claims for this material is that it will release silver over 3 days. In our laboratory testing under some conditions, we've shown that it has consistent release over 10 days. So it will depend a little bit on the wound environment as to how long it will persist on the wound and how long it will release, but it certainly has the potential for very prolonged release of silver, which could be really useful in exotics or in wildlife where you want to treat the wounds and then not have to handle the animal again any more than you need to. As I mentioned, the polymer layers can have an added protective effect. And in some instances, we use this as a sole dressing with no covering, or we can place it under any primary dressing. So we can place it under your dressing of choice, whether that's a Vaseline gauze or a hydrocolloid or some other material that is your preference. And it's bioresorbable, so you do not remove this once it's been applied to the wound bed. So a couple tips on how to use it I thought would be useful is, first of all, we use this with our other wound care methods. So we're not going to just take a wound and treat it with this and say it's all good. We're still going to do our debridement if we have damaged wound beds. And then we'll use our microlite to prevent the bacteria from taking over that wound surface. We can use it daily. It's non-toxic. We can stack the material up if we need to, or we can tile a wound if they're extremely large and get in total coverage of the wound. The microlite basically works where it's attached. So you would not just put one piece in a giant wound and expect it to diffuse silver through the whole wound. You really need to cover that entire wound surface. And then how frequently you put it on really becomes a clinical judgment based on the type of wound that you're dealing with. So if we have acute wounds that tend to be fairly effusive in the early stages, then the microlite may exfoliate out under the bandage. And since the bandages are going to become saturated with wound fluid, we're going to want to reapply that microlite every day as we do those bandage changes. But after a couple of days, these wounds typically begin to dry up, and then we can go to longer intervals with our microlite. We have shown that it releases silver as long as the wound beds are relatively dry for up to 10 days. Certainly, a reapplication every 3 days would be well within the time frame that you'd be getting consistent release of silver. And the reapplication is mainly due to how much effusion is coming out of the wound. So if they're highly effusive, you're going to reapply more frequently. If they're relatively dry wounds, then you can apply it at very long intervals. So just to show you a few practical application methods. First of all, I found that the material adheres better if the wound is relatively dry, but not desiccated. So if it's desiccated, it won't stick because it needs that fluid to be absorbed out of the interstitium to dissolve the polyvinyl alcohol. And it won't stick on normal dry skin, but it will stick on skin that's essentially got a moist dermatitis, for instance, and I found it to be fairly effective for that. So I'll blot the wound with a dry sponge to get any excess fluid off so it's not floating on a fluid layer. We're going to want to put the material down in the same orientation as the packet, so label side up or label side out. And then we can either apply it by contact, which I showed you in some of those previous videos, where we lay it on and let it spontaneously adhere to the wound, or we can apply it by direct pressure with gauze. And this has become one of my preferred application methods because it accelerates the adherence of the gauze. This is showing it being placed on a piece of porcine dermis in the laboratory. And we just take a completely dry sponge and just hold it down. And this helps push it into the micro contours of a complex wound surface as well. And as you do that, you can see that as it's starting to resorb and adhere to that wound surface. So a few case examples I thought I'd bring up. So this is one of our first cases that we did. And it's a cat that had an open wound on its hock after a tarsal arthrodesis. Been open for 5 months, treated with a wide variety of treatments and with very little effect. And when we started treating it with the microlite, this wound doesn't really look all that bad, but is absolutely stalled in terms of healing. And after a couple of days, we see a start of contracture. And by a month, this wound is totally healed. So when we plot out the effects of changing the wound management with the application of microlite, we've got a wound that's basically been the same for 5 months, and then very rapid contracture and closure. This is an example of a bulldog that had a pantarsal arthrodesis. The wound got infected and opened up. This bone plate has been exposed for a little over a month, and it's really has been going nowhere. This leg was treated with all sorts of antibiotics, including retrograde intravenous antibiotic therapy. And what was interesting here is we just applied the microlite right over the wound and right over the bone plate. And if you notice, in 1 day, this granulation tissue starts to extend over the plate. In 3 days, it's almost completely covered. I just found this was just amazing. By 11 days, it's completely covered up. And day 13, you can see it's much smaller. And after this time, the owner was treating it at home and it completely healed. These are some photographs provided for us by Jamie Payton from Paul Ramos, who went to Australia during the big fires and was treating the koala bears and the kangaroos that had a lot of burns, and particularly on their feet, where their pads were very damaged. And they really were very pleased with the effects that they got using the microlite on these animals. They felt like they had a reduced need of anesthesia and less frequent bandage changes. And they got what they felt was much better healing on these burn wounds. This is from a Dr. Gotthelf, who used this on what he thought was and what is a fairly bad traumatic foot injury. And they used the microlite on this material. And, within a little over a month, he was able to get really impressive healing of this wound. This is a quick example of a pressure sore in an Irish wolfhound that had been present for over 3 months and had failed all the conventional treatments, including wound care, padding, offloading, all the things that we normally do. And this is a case where bandaging, this is over the ischial tuberosity, bandaging this was just pretty much impossible. And so we used the microlite as the sole wound dressing. And what we found was within 5 days, it started to get smaller. This caliper shows the original wound size at 10 days. It's about a little more than half of its original wound size. And by 2 weeks, this is just a dried up crust that's completely epithelialized in that area. Another example, canine elbow hygroma, infected, necrosed the overlying tissue. And this had been open for about 2 months at this point. This advancing epithelium is undermined, so there's a shelf of tissue here. We treated this with the microlite and put the microlite even under this overhanging tissue. And within 5 days, this is all adhered down now. By 9 days, it's epithelializing and contracting. By day 12, we just have this kind of dried crust on there. And a little over 2 weeks later, it's completely healed. This case is just an example of one of our cases treating these multi-drug resistant staph organisms. This actually belonged to one of my former residents. The dog had had a tumor removed on its forelimb, and the wound got infected and opened up and was treated for about 2 months with various treatments for the MRSA and MRSA-SP. And when the resident came to me, the concern was that we were starting to get this expansion of this moist dermatitis, and the skin around the smaller wound was not looking very good. And what I thought was interesting with this case is we applied the microlite, which adhered all to the area where the moist dermatitis is. And within 1 day, that moist dermatitis is gone. And so now we're just dealing with the open wound. And by 3 weeks, this is completely healed. This is an example of a bear cub. And I have to apologize. I got this slide, but I was not given an attribution as to who provided it. I'm sorry about that. Hit by a car, had a wound on its back, had the dorsal spinous processes exposed, treated with microlite. And, within a relatively short time, this wound is basically healed tremendously over about 2 weeks. And so that's the end of the talk. I think I'm right on time. I'm hopefully doing okay here. And I'd be happy to take any questions.
On your applications, when you put that on, I noticed on some of the will peel off the excess around the edge of the wound. Is it necessary to peel that off, or just comes off by itself?
It's not necessary at all. I think it's more of a convenience factor that there won't be an edge there that might be able to dislodge some of the material on the wound surface. So usually I'll either peel it off like Bryden Stanley did in that one video, or I'll take a gauze sponge and kind of stabilize the material on the wound and then peel that edge.
I see. And most of those wounds that were healing in that, was that multiple applications over the 3 weeks?
Yes. So most of those were really following that recommended or suggested, I should say, protocol, because they were almost all relatively effusive at the time we got them. And so we would apply the material, bandage over it, in all of them except for the one pressure sore on that wolfhound. And then reapply the next day. And usually after about 3 days, then we would start going to either every other day or every third day, because the wounds were starting to look a lot healthier and less effusive. But that's where your clinical judgment will come in. Some wounds, depending on how traumatized they are and the type of bacteria that are on there, can take longer to stop being so effusive. The other thing that I do is on some of these wounds, is, you'll look at them and you'll see basically a slime layer on the top of the wound. And that, to me, that's usually indicative they likely have a biofilm. And so even if there's not any obviously non-viable tissue on that wound bed, I'll take a wet gauze and just kind of do a vigorous rub of that surface, because what we're trying to do is break down and disrupt that biofilm, which makes the bacteria within the biofilm more susceptible to killing. In the future, we actually have a second generation version of this dressing that contains gallium, and gallium will actually cause the bacteria to disassemble the biofilm. So that particular generation is going to be targeted at wounds with biofilms, with suspected biofilms.
Well, this is wonderful. We do have many fires out here and a lot of wounds to contend with, and you've given us a lot of hope to healing those. So thank you. Thank you very much for all your help. Does anybody else have questions?
Yes, and I know that Lori had mentioned that I should put some links in this talk. I don't have any specific links to this, but what I can do is provide my email address. So if anyone has any questions on particular applications, if they're looking to use this material, I would be more than happy to communicate with anybody and discuss what might be optimal ways to apply it and to utilize it.
Wonderful. Thank you so much. I do see in the chat some very informational, and thanks for the presentation. Great presentation. Thank you. So thank you everybody for joining us, and hopefully we'll see you all tomorrow for our continuation of our compassionate wounds and euthanasia talks.
All right. Thank you. A pleasure to be here.
Thank you. Thank you for your time.
Have a great day, everyone.